Welcome. Hello. I'm so glad to have the opportunity to be with you today and launch a series of webinars by my colleagues and I focused on gynecologic cancers. September is Gynecologic Cancer Awareness Month, and together we're going to try to bring some information that we hope will be useful for you as our audience and also all of our patients here at UCLA. I want to remind you that you can communicate with us through this webinar, and we're happy and we'll try our best to answer your questions. You can reach us through Twitter, and we will do our best to address any questions you may have during or after the seminar. So some of you may have known me from previous webinars, but I wanted to take an opportunity to introduce myself again and share with you the role that I play here at UCLA. I'm very grateful to be a physician here at UCLA. I'm a cancer surgeon and I serve patients at the Ronald Reagan Medical Center, where I do cancer surgeries and complicated gynecologic surgeries. I'm also very fortunate to serve our veterans at the West Los Angeles VA Hospital. In addition to that, I'm also a basic scientist, and I'm very excited to direct and work with my team at the Go Discovery Laboratory at the Broad Stem Cell Research Center, and our focus is really helping improve treatments for women impacted with gynecologic cancers. And so we kind of go back and forth. My role is dual. I go back and forth between patient care and performing research, while I was also teaching and training others here at UCLA. I'm also incredibly excited about my affiliation with the Ovarian Cancer Circle, inspired by Robin Babini. I've worked with Palinda Schimmel, the CEO and founder of the Ovarian Cancer Circle, and we've had a great collaboration over the year. This has been a tremendous community engagement, and through the incredible efforts of Palinda, and now a collaboration with the City of Los Angeles and Paul Koretz, Los Angeles City Hall has proclaimed September 18th Ovarian Cancer Awareness Day. And to honor that, the city is going to light City Hall as well as LAX in teal, which is the color for ovarian cancer. So here at UCLA, we really are focused on helping patients, providing excellent care, performing research, and having community engagement while teaching our students and juniors to carry on this mission. So as part of my talk with you today, I'm going to share with you a little bit about impact of genetics, advancements that have been made in genetics, genetic testing, and how has that helped us improve care of women with gynecologic cancers. In this slide, I'm showing you a picture of several types of ovarian cancer. Ovarian cancer, we think about it as one disease, but in reality, it's a heterogeneous disease, and there are many subtypes of ovarian cancer that actually look very different under the microscope. But most importantly, through a sort of an effort that was led by the National Cancer Institute, it became apparent that not only do these tumors look different under the microscope, they have very different genetic underpinnings, suggesting that there are different genetic alterations in these tumors. And this is important in how we approach these cancers. Similarly, for uterine cancer, the most common subtype of which arises from the endometrium, the cell layer that sort of is within the uterine cavity, you can see also that there's several types of uterine cancer. But not only that, through genetic testing, they have very different genetic makeup, and they have different genetic mutations. So I will say that cancer really is a genetic disease, and for us to understand cancer, it's important that we understand the genes and alterations in the genes that lead to cancer. So I wanted to just show a very basic slide to sort of look at what is a gene. So the gene is essentially the DNA, which carries, in essence, the code for a cell. And how does it do that? The DNA gets transcribed into a message called RNA. RNA is this intermediate, and some of the RNA in our cells can be then translated into proteins. And proteins, in essence, are the building blocks that make up the cell, and they're multiple cells together that create the tissue. So when we talk about a gene, we're talking about the DNA. Now, to give you a historic perspective, I think discovery of DNA was one of the biggest sort of discoveries in the history of science, and this was done through multiple investigators, one of which was this female scientist, Dr. Rosalind Franklin. She was a X-ray crystallographer, and she took images of DNA, and the images that she took, I'm showing one image here, demonstrated that DNA could be a double helix. And this was a big discovery that helped the team working on DNA, understanding the structure of the DNA. And sadly, Dr. Franklin battled ovarian cancer herself and died at a very young age of 38. So she is one of my heroes, and I wanted to talk about her and her contribution to the field. So really, then the field has evolved and moved on, and there was a big initiative which started in the 1990s, trying to basically understand and map all the human genes. And this was a collaborative effort that went on. And the findings through this analysis really helped us understand association with genetic changes and also diseases, some of which are cancer. So what does genetic testing mean, and who can get genetic testing done? Well, genetic testing can be performed in a woman who has a high risk of cancer, and I'll share with you what those risks are. And to do that, it's rather simple. The patient meets with a genetic counselor, blood is taken from her, the DNA is looked at, and then an answer is provided. Now, what about a patient who already has a diagnosis of cancer? How does genetic testing work for her? Well, there are two ways that we can do testing of her genes. One is we can take her blood and do genetic testing and understand that if she carries a predisposition that predisposes her to cancer. But also, we have recently started testing the tumor in the patient, and that gives us information specifically about genetic changes that may be happening in her tumor. And if you recall earlier, I showed you this slide where these cancers have multiple genetic mutations, and it's important to know about this. But the reality of the fact is that genetic testing is still underutilized, and it's estimated that upwards of 1.3 million people at risk for ovarian cancer have not had genetic testing yet. That is really important because we don't have early detection tests still for ovarian cancer. And as I will share with you, there are strategies that women can take to reduce their risk, which generally is recommended in women who are predisposed to this type of cancer. So this is a simple chart to show you who should get genetic testing. If a woman herself has a personal history of cancer, or if she has a family history of cancer, multiple family members are affected by cancer, genetic screening is recommended. And once it's performed, if the results are negative, then she can go to baseline screening. However, if the test is positive, then she may need to have special cancer screening done in addition to potentially risk reduction procedures that we'll talk about in a little bit. And this is showing you in a little bit more elaborate or more descriptive manner which women should consider genetic testing. So multiple family members among multiple generations always raises the possibility of a genetic predisposition to cancer. When cancer is diagnosed at a younger age, then we always think about possibility of carrying a genetic mutation that predisposes to cancer. So those women should get genetic testing. Grouping of cancers that suggest a syndrome, uterine cancer, ovarian cancer, colon cancer within the same family may indicate Lynch syndrome, and those patients should get testing. Women who are of Ashkenazi Jewish origin are also at higher risk for cancer. Higher risk of cancer carrying BRCA1 and 2 mutations, and it's estimated that 1 in 40 of these ladies may actually carry a gene mutation in BRCA1 or BRCA2. And then lastly and importantly, now the guidelines are that any woman who's diagnosed with epithelial ovarian cancer should get genetic testing. And the genetic testing, basically, it used to be in the past that we only tested for BRCA1 and BRCA2. However, since 2013 to 2014, genetic testing has now expanded, and we test beyond those genes. And I'm showing you a cadre or sort of a series of genes that are now tested for as our knowledge evolves and as we understand more about genetic changes that predispose to cancer, and also as the technology is evolving and we're better able to do genetic testing. So how does this genetic testing actually happen? Well, we're very fortunate here at UCLA to work with an amazing team. I work with a group of genetic counselors, to name a few: Rachel Shapiro, Wendy Conlon, Erica Silver, and others. But how it works is that the women, basically, the patient goes and meets with one of our outstanding genetic counselors. Her blood is drawn, the sample is submitted for sequencing, and again, you can see here, testing is done for a panel of genes. The information is shared with the patient, and the patient then knows, is she at increased risk for some types of cancer or not? So I'm just sharing with you some of these genes that we've talked about. So in BRCA1, BRCA2 carriers, we know that there's significantly increased risk of ovarian cancer, up to 54% in BRCA1 carriers, up to 27% in ladies who carry BRCA2 mutations. And I'm summarizing some of the other genetic sort of changes that can be predisposed to ovarian cancer. But the question becomes, if a woman carries this gene, what should she do? There always has to be a discussion with a physician. Often we see these patients as gynecologic oncologists and counsel them about their risk and the goals in life in terms of reproductive goals, etc. But the challenge with ovarian cancer is that to this date, we don't have effective screening tests for these ladies. We generally do pelvic exams and measure CA-125s every 6 months, but we really know that neither of these tests actually detects the cancer earlier. And that's why we recommend that once a woman is done with childbearing, she should consider risk reduction surgeries, which are fairly straightforward. The standard of care at the time is removing the ovary and the fallopian tube to reduce the risk of ovarian cancer. Now we've learned that the vast majority of ovarian cancers actually arise from the fallopian tube rather than the ovary itself. So there is research ongoing to look and see whether just removing the fallopian tube or doing the surgery in stages, removing the tube and maybe the ovary at a later date, could be an option for these patients. And why that is important is that the ovaries produce the good hormones for our body. They have impact. Losing ovarian function or losing hormones can predispose women to cognitive changes, cardiovascular changes, so it can have a negative impact. So there has to be a balanced discussion with the physician according to a woman's risk. Now, what if the genetic testing suggests that there's an increased risk for uterine cancer? And that predominantly that syndrome that we talked about earlier is the Lynch syndrome, and there are 4 genes that are associated with that. These ladies are at increased risk for uterine cancer, ovarian cancer, and colon cancer. But how do we prevent, or how can we diagnose uterine cancer early? It's generally recommended that these ladies get sampling or biopsies of the uterus. The uterine lining is where the cancer arises from, so that they're screened. We also do ultrasounds to keep an eye on their ovaries. And again, ultimately, once they're done with childbearing or approaching menopause, it's recommended that they have undergo removal of the uterus, the fallopian tubes, and with some genetic mutations, consider removing the ovaries as well. So far we talked about how genetic testing can help us with prevention, but how can it actually help a woman who's already diagnosed with cancer? Many of my patients ask me, I already got ovarian cancer, why do you think I should do genetic testing? Well, there's now evidence that has emerged that ladies who carry BRCA mutations or mutations similar to BRCA may be candidates for taking an oral drug called PARP inhibitors. And these PARP inhibitors, I'll share with you a little bit their mechanisms of action in a bit, can help prevent the cancer from essentially recurring. And this is a well-tolerated treatment. It's not without side effects, but something to be considered in ladies who have ovarian cancer and carry BRCA mutations. But also for women with uterine cancer, if they have recurrence of disease, this genetic testing can help us figure out, are these patients potentially candidates for immune therapy? And I will talk about this a little bit more. So how do these PARP inhibitors work? Those of you following the field may have heard about these drugs. They've been in the news and they've now really been incorporated into practice, in our practices, particularly in ovarian cancer. So imagine, we talked about DNA earlier, so imagine this is the DNA in the cell, and the cell constantly is undergoing replication process. During the replication process, just randomly, you can have errors that happen. And normally, PARP enzymes very readily can repair this defect. Now, when you give an inhibitor of this enzyme is not working. So this repair that normally, or this DNA damage that normally would be repaired, now goes unrepaired. Now, it's interesting because in cells that do not have a mutation in BRCA, meaning cells that are normal, the cancer cell goes on and lives because these defects are repaired through another mechanism, primarily mediated through the BRCA and other genes. However, in cells where there's a BRCA mutation, this genetic damage is not repaired, so the cancer cell goes on and dies. This is the concept here is called synthetic lethality. But to really simplify it, it means that these PARP inhibitors primarily target cells that have a mutation in BRCA. And that's why PARP inhibitors work best in women who carry BRCA mutations. Now, what about immune therapy? So here we're showing you a picture of a tumor cell that is interacting with an immune cell called the T cell. The T cell usually has an excellent mechanism through the T cell receptor to recognize the tumor cell and kill it. But many cancers are smart and they upregulate proteins that then can interact with the T cells and basically dampen this response or in essence put the brakes on this killing capacity. Now, there are new drugs on the market, some of which I'm showing you on here, pembrolizumab, which can bind to one of these sort of receptors and block this interaction. So by blocking the interaction, this dampening response is not happening, and now the T cell can go on and attack the tumor. So patients who have mismatch repair defects, women who carry Lynch mutations, for example, tumors that have this kind of characteristic have a higher likelihood of responding to this type of a treatment. Again, demonstrating how genetic testing is important. So far I've talked to you about genetic testing of the patient, but I shared with you earlier in the talk that we can also do genetic testing of the tumor. So how does that happen? So many times when a patient is diagnosed with cancer, the surgical management, we remove the tumor. Sometimes we can take a biopsy of the tumor. The tumor is then taken to the pathology laboratory and it's used for diagnostic purposes, but also this material can be sent for genetic sequencing, and then the patient's tumor can be molecularly profiled. These platforms are called next generation sequencing. And now there are a few of them that are FDA approved and really have helped us in personalizing treatment of patients with cancer. The idea here being precision medicine, so that you treat the cancer based on genetic changes within the tumor rather than where the cancer actually arises from. These results, actually there's a turnaround time that's less than 2 weeks, and we were one of the pioneers at UCLA to incorporate this into our practices and utilize this frequently. So how is this information helpful? Well, sometimes in the tumor cells, when we sequence them through this next generation sequencing, we find that they have sort of this high mutation burden. What that means basically is that normal cells basically have well-regulated protein production. Cancer cells have multiple genetic mutations, and sometimes on their surface they express these neoantigens and they're recognized better by the immune system. And through this kind of genomic analysis, we can identify and select patients who may be candidates for immune therapy. But what about other treatments? Where there are other treatments like PARP inhibitors? And what we've learned over the years, and I'm showing you here a simple diagram of what I just explained to you earlier, how the cell replication happens. And there are many players that are involved in here, BRCA1, BRCA2, RAD51, and there's a whole group of these proteins that work together. And even if a patient herself does not carry a BRCA mutation, sometimes in her tumor, we find a BRCA or a BRCA-like mutation, in which case she could then be a candidate for PARP inhibitors, particularly if she has recurrence of disease and also in patients who've had multiple lines of chemotherapy. So this is sort of, I wanted to share with you what we're doing in clinical practice. But I also shared with you that I am a scientist and I have a research lab, and I'm very fortunate to not only have incredible clinical colleagues that I work with here at UCLA, but also to have amazing basic scientists that we collaborate with all of us together want to do research that can help improve care of patients. And one of the lines of research that we're working on is targeting a protein called P53. This is a protein that is mutated in 97% of ovarian cancers, and actually in half of all cancers. So it's a very important protein, and there are genetic alterations of this protein in many cancers. Through a collaboration here at UCLA, we've been able to test a peptide that can actually restore the function of this mutant P53. I'm not going to go into a lot of details about how this peptide works, but there was a great transdisciplinary collaboration with my colleagues in structural biology, and it really has been a fascinating sort of part of science to be able to participate in. And what we have previously shown is that the peptide in and of itself can help target some ovarian cancers. Ongoing work in the lab in collaboration with these groups of colleagues of mine is now testing whether if we can add this peptide to standard chemotherapy, in this case carboplatin, can we help improve outcomes of ovarian cancer? And we're doing these in laboratory and experimental models. But again, I want to emphasize to you that understanding the genetics of the cancer is important. Knowing that P53 is mutated in so many of these cancers, and then coming up with a peptide that can target that mutation is how we can bring about new drugs that can be more targeted to the patient's tumor. So, in my last slide, I really wanted to share with you what I think the wave of the future is, and some of this work is already ongoing. So I'm sharing with you the NCI Match Trial, which is a precision medicine clinical trial. And to make a long story short, the idea with this trial is that patient has genetic testing, tumor testing is done, genetic testing of the tumor is done, and the right drug is matched with the right tumor based on its genetic makeup, rather than where does the tumor originate from. So the genetics of the cancer is important in figuring out what drug matches that patient. And again, this is a precision medicine approach. The idea and the hope, and this is a clinical trial that is ongoing, the idea and the hope is that one day we're able to treat patients specifically for their own tumor subtypes. So here at UCLA, we've had this long-standing tradition of our multidisciplinary tumor board. This is really a phenomenal meeting where we sit as gynecologic cancer specialists at this meeting, along with colleagues from pathology, radiology, radiation oncology, medical oncology, geneticists, and together we sit, and every patient who walks through our doors here at UCLA is discussed at this tumor board. Every patient that we operate on and has a cancer diagnosis is discussed at this tumor board. And the idea is that we can come up with treatments according to the discussion in this multidisciplinary group. And the goal is really, and we are moving in that direction, is to really making these tumor boards molecularly based. And molecularly based on genetics of the cancer, genetics of the patient, coming up with treatments that are more tailored to each individual patient. So I hope that this talk webinar was informative for you. I hope that I was able to share with you how genetics of the patient and the genetics of the cancer can have an impact on treatment of gynecologic cancers. I hope that I was able to share with you how we as clinicians utilize this information, and also what their ongoing research is to really make cancer a much more personalized treatment approach. So with that, I want to take a few questions from our audience. So the first question is the following. Does it matter if the family history of cancer is on my mom's or on my dad's side? That's a great question, and I get this question a lot. It really doesn't matter, because sometimes patients come in and say, well, on my mom's side of family, there is no cancer, but on my dad's side of family, there's breast cancer, ovarian cancer, prostate cancer, and is this relevant, or is this important? The answer is yes. It does not matter whether the family history is on the mom's side or on the father's side, because genetics is determined by both genes that are inherited from mom and dad, and either of those genes that can predispose to cancer and gynecologic cancers can be inherited from either parent. Okay, I have another question. So, I don't have any daughters. Should I be concerned for my sons? Is genetic testing necessary because I really don't have any daughters, but would it have any impact on my sons? This is another great question, and I get asked this question all the time. So similarly, a mom can pass on genes to both daughters and sons. And some of the very genes that we talked about today, genes that predispose to, or the genes that are important for Lynch syndrome, even the BRCA1 and 2 genes can cause cancer in males as well. Those include colon cancer in Lynch syndrome, prostate, melanoma, and BRCA1 and BRCA2. So the genetic testing information is important both for sons and daughters, and they equally can pass it on to the next generation. In essence, we think about the concept of sort of cascade testing. If the index person, the person who is impacted by cancer or has a positive genetic test, it has relevance to all family members, including daughters and sons, and then they would have to get tested. So another question, if I have a family history of cancer and I want to get genetic testing done, should everyone in my family get genetic testing done as well? So it's often recommended that the person who is, ideally, the person who is diagnosed with cancer gets genetic testing done. If that person has a genetic mutation, then other members of the family should get tested as well and be checked to see whether they carry this mutation or not. If there is only a family history of cancer and you are concerned about cancer, then it's important that you get genetic testing done. If your genetic testing is positive, then other members of your family can be tested as well. Well, it really has been a pleasure to be with all of you here today. I hope that this talk was informative. And it's been a pleasure and honor to be with you. And we look forward to seeing you at UCLA. We are actually, I serve patients, as I mentioned, at UCLA Ronald Reagan Medical Center. I'm happy to help with the care of any patient who wants to see us in clinic. I've been very for the past several years and now decades. And together as a team at UCLA, we take care of patients. We take it very seriously. We consider it an honor. And I'm so appreciative for your time today. And thank you for joining us in this webinar.